Hello, everyone. This is Leslie Seidel. I'm speaking to you from the offices of the Institute for Research on Public Policy in Montreal. And I'm pleased to welcome you to our webinar today on bilateral health agreements between the federal and provincial territorial governments in Canada. This is part of a new research program, which I'll speak about in a moment, and it is leading to, or it's part of the work on a publication that will be coming out next week on the same topic. We have a record enrollment for this webinar, although it's only our second one. So, nevertheless, we had 310 people sign up. We won't know until later how many people are actually with us at the moment, but we had people sign up from all 10 provinces and 3 territories, as well as the US, Portugal, the UK, and Australia. And maybe during the questions, some people will give an indication of where they're from. It's not necessary, of course, but anyway, we're very pleased at the level of interest in this webinar. As I mentioned, this is part of a new research program. It's called Canada's Changing Federal Community. And in the program, we are looking at intergovernmental relations, institutions of federalism, fiscal transfers, but we're also looking, as in the project that Gregory Marchildon took on for us, we're also looking at the relation between public policy and the processes and institutions of intergovernmental relations. We're also in this program, and we'll no doubt have a webinar in due course, we're also including a number of Indigenous issues, particularly Indigenous governance and the relation between Indigenous communities and the federal, provincial, and territorial governments in Canada. We published our first paper in September, and the Gregory Marchildon paper coming out next week will be the 5th one in the series, and we have another one coming out in the middle of December. So we're off to quite a good start. Anyway, enough on that. So look for the Gregory Marchildon Insight next Tuesday, December 6th. It'll go up online on our website first thing in the morning. And as most of you probably know, all our publications are open access. There's no charge. So our speaker today and the author of the paper is Gregory Marchildon. He holds the Ontario Research Chair in Health Policy and System Design at the Institute of Health Policy Management and Evaluation at the University of Toronto. He's a fellow of the Canadian Academy of Health Sciences. He taught a while ago for 5 years at Johns Hopkins University School of Advanced International Studies. He served as Deputy Minister to the Premier and Cabinet Secretary in Saskatchewan, so he has experience as a practitioner in government, very senior level experience, and he was also Executive Director of the Royal Commission on the Future of Healthcare in Canada, often known as the Romanow Commission. So I'm sure you will agree that our author is highly qualified to take on this topic, and so I'll pass things over to him now for his presentation, which you'll see on the screen, of course.
Thank you very much, Leslie. And I just want to start by saying that there's always been a great deal of controversy concerning the different dimensions of federal health transfers to provincial territorial governments over time. And these have focused in 2 areas. One is concerns the conditionality of the transfers, and depending on your position on this, the question that is asked is, do the conditions actually uphold a certain set of national standards or encourage new initiatives? Or on the other hand, do they simply distort what would otherwise be entirely appropriate provincial and territorial expenditures? And then there's always been controversy on the money itself. What amount should flow? What are the criteria that should govern the amount of money that flows? In other words, how is the absolute level set? And then how is the distribution between and among the provinces and territories? Again, the debate was triggered recently at a meeting of health ministers on October 18th, when the suggestion was made that perhaps the $3 billion that had been promised for home care and similar investments in the last federal election might come in the form of bilateral health agreements between the federal government and individual provincial and territorial governments, rather than a top-up to the current Canada Health Transfer. The purpose of the Insight paper that's going to be released on December 6th is to examine the instrument of a bilateral health agreement, and today that's what we're examining. Next, please. So what we'll be presenting today is to look at the rationale for bilateral health agreements, the history of their use, what policy lessons we can possibly extract from this history, the desirability of the instrument, as well as its fiscal and political sustainability. Next slide, please. So in terms of the current impasse, it really has its roots, of course, in a decision made back in December 2011 that the escalator in the Canada Health Transfer would be reduced from 6% to 3% beginning in the next fiscal year. And there has been a fair amount of contention over that issue and some desire by provincial and territorial governments to see that either changed or at least mitigated in some way. But in the meeting on October 18th, the Federal Minister of Health rejected provincial demands to address the Canada Health Transfer first before any discussion of what would be done with the $3 billion in terms of home care. And the federal government also made it clear that it was not really considering delaying or stopping the implementation of the 3% escalator. Now, the provincial and territorial governments have so far responded mainly negatively to both the amount and the form of the $3 billion. First, on the amount, the $3 billion is considerably less than the $60 billion that provincial and territorial governments estimate they will lose over the next decade due to the decline in the Canada Health Transfer escalator. And then some provinces also reject what they consider to be the additional conditionality that might accompany a bilateral health transfer. Next slide, please. Now, given the opposition of provincial and territorial governments, what might be the reasons that the federal government would still be proposing a bilateral health transfer agreement? Well, the first is that lies in the general perception of a lack of accountability in terms of the health accords of the last decades, as well as some disappointment with the results in terms of health system change and performance as a result of the health accords, particularly the 2004 accord called the 10-year plan. And this perception, I think, has been fortified by the media, think tanks, and academic commentators who have generally argued that there was an enormous amount of money that went out the door as a result of the 10-year plan, and there was very limited return. Now, the provincial and territorial governments prefer a top-up to the Canada Health Transfer because it does not impose additional obligations and it would not be time-limited funding. And I think we can understand these reasons perfectly well. But I would like to try now to put all of this, this dispute into context by examining the history of health transfer agreements in general. Next slide, please. We're going to spend a little bit of time just looking at this history I don't want to bore you to death, but it's important to understand that that there is actually a fairly, what I would say is rich experience with health transfers and different types of health transfers in the history of this country. The first thing to note is that I've organized this history according to two criteria. One is the degree of conditionality, either loose or tight, and the second is whether or not the transfer involved a bilateral agreement between the federal government and provincial and territorial governments. Tighter conditionality was a feature of the earlier health transfers. You can see this in terms of the national health grants that funded numerous areas that were deemed strategic at the time and were often perceived to be essential to the creation of an environment conducive to the implementation of universal hospital coverage in the country. And that came under the auspices of the Hospital Insurance and Diagnostic Services Act of 1957. And that was accompanied by bilateral agreements between federal and provincial governments. Now, these agreements imposed a high degree of control through regular monitoring and inspections, and, if I can quote Monique Bégin, a veritable army of federal civil servants charged with auditing provincial bills and repaying half of those bills. In addition, of course, there was on-site inspection of hospital beds in each province to determine eligibility for cost sharing. By the 1960s, things had changed. The Quiet Revolution in Quebec brought to office a government that refused to accept this high degree of conditionality associated with Hospital Insurance and Diagnostic Services Act. So in cost-sharing universal medical care coverage, the federal government dispensed with these detailed bilateral agreements. However, there was still a high degree of conditionality, the 4 national standards in the Medical Care Act, plus effective holdback of funding to provinces until federal government was sure, in fact, that the conditions were being upheld. Now, in 1977, we see the introduction of established program financing and the block funding regime that we have been living with ever since. So this really marked the transition to an era of looser conditionality. This was the quid pro quo for the federal government, reducing its fiscal risk through a new funding formula that was really based on economic growth rather than on provincial territorial health spending. And this is where we've largely lived, is in that upper left-hand quadrant of the diagram. Now, there have been some modest exceptions to this. One is the Primary Healthcare Transition Fund Agreement, which was introduced in the 2000 Accord. It was for, by the standards of the block transfer, a relatively small sum of money, $560 million. And the Patient Wait Times Guarantee Trust Fund, and that was $612 million. Again, this is considerably less amount of money than the transfer and could be seen as simply an addition or a supplement to the main transfer. Next slide, please. Now, what policy lessons can we extract from this experience? Well, unfortunately, there's been very little evaluation of health performance outcomes, at least associated with these different funding regimes. And they weren't evaluated according to such criteria. It would have been difficult in any event. It's hard to isolate the transfer and its effect in terms of health system performance. So I've decided that it might be more useful to focus on process criteria, and I've identified 3. One is accountability, at least in terms of the Government of Canada and Canadian taxpayers, since the money for health transfers comes out of federal government revenues. The second is conditionality in terms of achieving identified pan-Canadian objectives. Now, it's important to note that these can be determined by the federal government unilaterally or through an intergovernmental bargaining process, such as a First Minister's meeting or a Health Minister's meeting. And the third is flexibility in terms of leveraging potentially useful health system innovation at the provincial and territorial level that could become pan-Canadian in scope if successful. Next slide, please. So this leaves two choices. If the bilateral health transfer agreement instrument is chosen, the devil will lie in the details. And the type and degree of conditionality will determine whether it falls into the left-hand side or the right-hand side of the diagram. Now let's look at this in terms of the process criteria that we have just reviewed. Next slide, please. First, accountability. The signing of an agreement creates an accountability relationship that otherwise hardly exists. And on this point, and I can tell you from experience that federal, provincial, territorial communiques do not create real accountability of this type. But everything depends on what is actually in the agreements. So that the practical utility will depend, and I've identified 4 fundamental areas, but there are other areas that could be important as well. But the first is the nature and degree of oversight that's written into the agreement, the enforceable sanctions that are part of the agreement, the clarity and effectiveness of any dispute resolution mechanism in the event of non-compliance by either party. Often it's perceived non-compliance by either party. And the final is the amount of information sharing and transparency that's actually afforded the parties through the agreement itself. Next slide, please. Conditionality. The success of this, the instrument, depends in part on it being accepted as a funding flow that is actually separate from the Canada Health Transfer and that's not being used to finance current operations. These standalone bilateral agreements are generally temporary in any event. They should be voluntarily. It should be up to the individual provincial or territorial government to decide whether or not it wants to participate. And then it's up to, of course, in making that decision, the provincial or territorial government has to decide whether the initiative fits with its priorities and game plans or not. Now, there are also some constraints on time and money that would likely force the federal government to set some boundaries on the bilateral health transfer agreements, including the total funding envelope and its allocation, and the number of years the agreements will run. The negotiating time involved, if these are not settled in advance, would probably be too burdensome on the federal government if it had to renegotiate each of these government by government. As an interested observer, I would say that it would also be very beneficial to stipulate in advance common expectations concerning transparency and the requirement for rigorous and independent evaluation of each bilateral initiative. Next slide, please. The next area that I want to review is flexibility and the use of this instrument to spur different experiments across the country. Now, in my view, this could be the most useful aspect of this approach. But to be effective, it would need to be set up like similar to any experimental design with effective evaluation throughout. It would also mean that there would have to be meaningful differences among initiatives. So this would separate it from, for example, the national hospital bilateral agreements when universal hospital coverage was set up, because those agreements were almost identical. Here, there would have to be very meaningful differences so that useful comparisons could be made among the experiments in different provinces and territories. The results would then be publicly disseminated and then analyzed by anyone who would have the ability and the skills to do so. Now, this approach would put a premium on provincial and territorial agenda setting and innovation, but it would also be very respective in this sense of the provincial and territorial role in healthcare and its administrative capacity as demonstrated over time. So what's the cost? Well, of course, the time involved in provincial and territorial governments setting up an innovative design and the effective blueprint, and the federal government's willingness to accept differences and its ability to be patient in terms of being able to judge the policy merits of the results. Next slide, please. So what is the fiscal feasibility of this approach? Well, the first thing to note is the amount of money is marginal relative to the Canada Health Transfer. Whatever the sum that's invested in such a strategy, and let's just take, for example, the $3 billion, it's considerably less than the Canada Health Transfer, which is one of the single largest expenditures of the Government of Canada. In fiscal year 2015-16, this was $34 billion. Compare that to equalization, which was $17 billion, or the Canada Social Transfer, which was $13 billion. Moreover, the Canada Health Transfer was the fastest growing of all three transfers. So it's a far less expensive option than the alternative, which is to increase the 3% escalator that's currently set for next year. So from that perspective, it's certainly feasible. It's also fiscally neutral. When you compare it to what the other options are, you could certainly put the $3 billion into the Canada Health Transfer as a top-up, but there's really no gain in terms of fiscal savings. You could also create a special purpose transfer trust without bilateral agreements, but again, fiscally that's neutral. So in general terms, it seems rather neutral, but it could in the end be actually less expensive due to the possibility that not all provinces or territories may opt into the arrangement. Next slide, please. So what is the political feasibility? Well, this is in some senses the most difficult question of all. As you know, there will be an upcoming meeting of First Ministers in the Environment next week, and no doubt health will come up. Federal budget decisions have to be made soon, so pressures will mount for a decision. I think there are a couple of factors both for the political feasibility of this approach and against the political feasibility of this approach. The arguments for, well, number one, the provinces and territories certainly could use the additional money given their current fiscal situations. Most are currently in positions of deficit financing. and definitely could use the extra injection of money. The second is precedent in terms of the Primary Healthcare Transition Fund, the Patient Wait Times Guarantee Trust, and perhaps even looking at an instrument like Canada Health Infoway, which is mainly made up of federal money. We do have experience with this kind of instrument. It has been accepted for the most part, particularly when the amount of money has been marginal relative to the main transfer. Now, what are the arguments against? The first is that there is currently a consensus against this approach by provincial and territorial governments who want to discuss the Canada Health transfer before anything else is discussed, and stand and continue to stand in favor of a top-up to the Canada Health transfer. The second is Quebec's long-standing position and opposition to what it has termed federal intrusion in areas of social policy, which it views as provincial jurisdiction. This, of course, is done through the introduction of conditionality, and in such situations, Quebec has often argued the right to opt out with financial compensation, and that would likely occur in this case as well. Next slide, please. So we can get to the questions as quickly as possible. I'd like to conclude on the following. I think that the bilateral agreement approach can work in defined areas, particularly where reforms are very carefully delimited and defined. So this could be, for example, in home care. Medically necessary home care is narrowly defined, for example, in the Romano report, or for specified complex conditions, a few of which are easily identifiable and can be monitored. And it can work also in areas where, for example, where governments are looking for innovations and are looking for new ways of doing things, but require the extra funding to be able to pursue those innovations. And these innovations could, in and of themselves, act as demonstration effects in the rest of the country. So what is the likelihood of this instrument being used? Well, I think this really depends on the federal government's political firmness, given the opposition of many provincial and territorial governments. It also depends on the federal government's own policy ambitions. What's it really trying to achieve here? Does it have a deep-seated desire to facilitate, for example, bold provincial and territorial policy experimentation? Or is it looking for one particular type of delimited health reform change? What is the extent of the federal government's desire for greater accountability? There's been a lot of rhetoric on the issue. The question is, what is the reality of that? And finally, what kind of coalition of willing provincial and territorial governments would emerge after a First Ministers meeting, assuming that it is clear that the $3 billion will not be funneled into the Canada Health transfer as a top-up. I want to thank you very much for your participation today, and I very much look forward to your questions.
Thank you for that very good presentation. Covered a lot of ground and has left us with some points to explore. You can send questions, those of you who haven't been on a webinar before, by typing in the box on the bottom right-hand corner of your screen. My screen says enter chat message here. So please send your questions or observations that Professor Marchildon will respond to. To get the ball rolling, I have one. You spoke at various points, including at the tail end, about accountability. And we hear a lot about that. But accountability is one of those concepts that really depends where you're sitting. And obviously for the federal minister and the senior officials, it could well have different meaning than for people in provincial governments, provincial health departments, and so on. You referred at one point to accountability to the government of Canada, and you had "and taxpayers" in parentheses. To what degree there's a tool that's often used, which is public reporting. Sometimes it's described as reporting to citizens. To what degree can that provide a sufficient level of accountability for the federal government to be satisfied? Or does it require something more demanding? And if so, what might that be, without obviously getting into the terms of a potential agreement?
Okay, well, there's a couple of things that it would mean beyond public reporting, although I think the public reporting is absolutely critical so that there's public oversight and there's accountability back to the general public. Whether the public means taxpayers as taxpayers or as citizens or as residents of provinces or territories. So one is obviously on meeting the timelines that have been agreed to. And generally in such bilateral agreements, there are very clear timelines set out. And there are thresholds and commitments that need to be made by certain timelines. The second is in terms of the use of the money for the purpose intended. And there needs to be a very clear indication that there has been the enumerated investment in that area. I would not see this as conditionality in meeting health system performance targets, because it would be questionable whether that you could link a innovation or a health reform directly to certain performance outcomes. But if you could identify either some outputs or some outcomes that both parties agree are a direct or could be interpreted as a direct consequence of that change, that could also be written into the agreement, and certain expectations set out in at least notional in terms of what is hoped for. And of course, the reporting on all of those health system outcomes.
Thank you. I've got a question here, getting into the politics of transfers. If Quebec tries to get out of the new transfers with full compensation, how likely is it for other provinces to follow suit? What response do you expect from the federal government should that happen? You'll be looking for your crystal ball. I'm sure you can't respond to all of that, but I'll let you try.
Well, first of all, the assumption here is that the federal government would agree to in a sense, an opting out with financial compensation. And I said earlier, the instrument's not likely to work in that situation, that this should be seen as a voluntary initiative which provinces can choose whether to opt in or not. If a province has the right to opt out with financial compensation, I'm sure that other provinces will demand exactly the same kind of treatment, and then it becomes effectively like a top-up to the Canada Health Transfer, perhaps even more unconditional than that, in the sense that it is not necessarily even linked then to the Canada Health Act. And the Canada Health Transfer has a direct linkage, of course, to the standards in the Canada Health Act. So the answer is a simple one. I don't think that that's a viable strategy for the bilateral health transfer agreement approach.
Okay, I have another question here, getting into some of the emerging needs. What are your thoughts on the most viable transfer to achieve a targeted increase in funding for mental health care in light of the long-standing underfunding in this area?
Well, it depends what you mean by mental health care. That can cover a huge number of services, providers, etc. And in this kind of a delimited and highly defined transfer, you would have to define what area of mental health you're trying to change quite dramatically. On the other hand, you could have what would be effectively a kind of an innovation fund in which provinces could choose how to experiment in terms of mental health interventions. And those could be evaluated in terms of their effect, but the federal government would, in a sense, be facilitating, encouraging very different experiments. And the provincial and territorial governments individually would be determining what would be the priority interventions in terms of mental health that would change the game, if you like.
Here's another question. This is a good one. How would you describe the success or not of the Health Council of Canada on reporting on outcomes from the 2004 Accord?
Well, I think the Health Council of Canada did the best that it could with the tools that it had. And it was limited, very limited in what it could do. And in a sense, what governments allowed it to do. And this is always going to be the problem associated with an agency which is a creature of federal, provincial, and territorial governments. It's answerable to those governments. And if it had been given more tools, if it had been given greater autonomy, and it had been given the information, and this is critical, as well as the ability to evaluate in a very rigorous way from the beginning these changes, then I think it could have done a much better job, but it never had the opportunity to do those things. So its report that did come out, in fact, its last report, was certainly far better than anything that we had before, but not nearly what we could have done if we had given the Health Council of Canada the tools it needed to be able to perform that function.
Okay, we have another question, somewhat in the crystal ball category. Is there scope for bilateral agreements that are national in scope, with all provincial and territories agreeing to a given innovative pilot program and receiving funding to conduct it?
Well, in that sense, I'm not sure why you would even need the bilateral agreements. They would be virtually identical in nature. It might increase the accountability a bit to have just the existence of the agreement, but it probably wouldn't perform a function much beyond that. But it's certainly possible through the intergovernmental process for all three orders of government to agree to such a pan-Canadian initiative and to bind themselves in that way. There's nothing stopping them. It would be, however, impossible, I think, for the federal government to unilaterally try to impose such a program on the provincial and territorial governments.
Another participant has asked, given that provinces and territories are responsible for the delivery of healthcare, and the federal government funds a relatively small share of healthcare spending, what degree of influence is reasonable for the federal government to expect in setting priorities for the sector, except what it has in the Canada Health Act?
Yes, the question you're asking is really the most important question, because for what is a relatively modest amount of money, the federal government would like to set up an accountable and more conditional program. The real issue here is whether this is a national program that it wants to be permanent, similar to Medicare, but it's only willing to fund through a temporary set of bilateral health transfers agreement. I think everyone would agree that's unreasonable. What is reasonable is to establish either a change that's very delimited and somewhat experimental in nature, with the idea that perhaps if it's successful, it then could become part of the Canada Health Transfer later on, in a sense part of an established program of Medicare. That might be reasonable. It is more than reasonable for the federal government to try and facilitate innovation that the provinces and the territories determine in terms of priorities, in terms of the actual design, but the federal government, in a sense, helps along through cost sharing with the provinces, and does so through bilateral transfer agreements. That is, I think, entirely reasonable in the circumstances.
Okay, I have a question. How will Indigenous communities be considered?
Well, I have no idea. That's certainly a question I can't answer. I do know that that is a priority of the current federal government administration. They would likely be keen to ensure that Indigenous health is an important part of this. If they choose to go down the road of encouraging innovation, I am sure they would be very welcoming of proposals from provincial and territorial governments in which Indigenous health is a major part. And as we all know, that there is considerable work to be done in this area. And one of the reasons that Canada does have poor outcomes in certain areas is directly a consequence of the poor health status of Canada's Indigenous communities, many parts of the country.
Okay, we have a question that's come from London, England. Thank you for that. The participant wants to know whether there's a risk of gaming in the bilateral negotiations, whether there might be a first mover advantage or disadvantage.
There's always a risk of gaming when this kind of arrangement is set up. I would say that there would be a first mover advantage in this situation. The first provincial or territorial government out of the gate with a blueprint, with some very good ideas. The federal government will be under some pressure to get this off the ground, and would be probably pretty willing to, or more rapidly willing to agree. At the same time, federal government knows that it's setting a precedent with any bilateral agreement, but at the same time, if it sets the right kind of precedent, it will be in a rush to try to sign the agreement. So I would say it would be the advantage to those provincial governments that move first.
Okay, another question. Can we learn anything from federal provincial agreements in other areas, other sectors, how some of the hurdles were tackled and addressed?
Yes, I think that we need to understand much better than we do infrastructure agreements between the federal government and provincial and territorial governments. There's a long history of these infrastructure agreements. And to the best of my knowledge, there's actually very limited literature on this. So there would have to be a fair amount of research to generate the kind of data and analysis that would allow us to learn from that experience. But I think that could be very important. Also, within the health sector itself, we have been funding, and the federal government has largely been funding initiatives through intergovernmental bodies, whether it's Canada Health Infoway, etc. And these bodies in turn enter into agreements with provincial and territorial governments. Again, this would be an experience well worth evaluating to determine whether this is really a productive approach.
Another participant refers to a major bottleneck in the system, which is absence of pan-Canadian detailed data. What do you think about the approach of no data, no money? The participant refers to this as a string.
Yes, I mentioned that in my presentation. I think that there has to be transparency, and transparency involves exchange of data. In fact, there probably needs to be very detailed provisions in such bilateral agreements concerning data and its both production and dissemination. There is in Canada the existence, of course, of the Canadian Institute for Health Information, which has been doing that job for some time. The question is for data that goes beyond what is in the repositories of the Canadian Institute for Health Information. And some of these data are actually held by private groups, whether they're provider organizations and the professions, or by private healthcare organizations. They may be private, not-for-profit, but they're still independent of government, and that requires you to bring in other partners to come up with these data sharing kinds of arrangements.
Okay, we've got another quite broad question here. Doesn't it seem that we are fighting the last war in trying to duplicate the 2004 Accord when the political, economic, and social environments are drastically different 12 years later?
Well, it's for sure there's one big difference in the environment. It's we don't have the fiscal room that we had back in 2004, for example. As I said, most provinces are facing both very large public debt, but more importantly, they're facing annual deficits. Some have been now for a few years. And they just have limited room to move. Federal government has a little bit more fiscal room, but that has now largely been used up, and the federal government too is now running a fairly sizable deficit. So we are in a different situation. We're in a slower growth situation, and based upon the forecasting I've seen, it doesn't look like we're going to be experiencing rapid growth anytime soon. So we have to take that into consideration. Money is more limited. We need to be much more careful in its use, something that we should always be in the area of healthcare anyway, but we have to be particularly careful at this time. The opportunity costs for provinces are severe in terms of other areas that require investment. So healthcare cannot have the privileged position that it enjoyed perhaps 10, 12 years ago.
Okay, we have a question here that concerns the fact that in a number of provincial governments, issues that might be seen as principally health issues are the concern of more than one department. The participant mentions that the departments are often not as well coordinated as they might be. I'm paraphrasing the question a little bit, but my sense is that the gist of the question is the following: how effective can these bilateral agreements be in situations where issues are more horizontal? The participant gives the example of child and youth mental health.
Yes, and I think this it speaks to the ability and capacity of individual provincial or territorial governments, because the onus would be on them to organize themselves internally in a way to be able to deliver in a multi-sectoral, multi-departmental way. And when you're talking about population health, the determinants of health, you're not just talking about a individual provincial government, for example, you're also talking about local governments. So even coordination within a single government may not be enough. There may be other partners that are going to be necessary, and those will be local governments. And in the case of Indigenous healthcare, as we all know, in the case of many Indigenous governments in Canada, they need to play direct roles, and they're going to be largely independent actors, and they need to also be partners. You can't simply impose these kinds of policy interventions on those governments. So it's a complicated piece, and it takes effort, creativity, and ability for governments to put together such a blueprint that would involve that kind of interdepartmental, intergovernmental kind of initiative. It is possible, but it is challenging.
Okay, we had a question a little while ago. I'm getting a lot of questions here, but I'm finally getting back to this one. We keep talking about money, but Canada already spends more per capita than pretty much any other Western country except for the US. Can you speak to this, please?
Well, this is the fiscal sustainability issue. Actually, Canada is more in terms of public healthcare spending as opposed to total healthcare spending. Canada is actually in the lower half of OECD countries, not in the highest end. So it's, you know, a part of our issue when it comes to total healthcare spending is private healthcare spending, and there's nothing that a provincial or territorial government can really do about that. So I have to focus on governmental health spending, and that is not nearly as unsustainable as the question might indicate, given the data that we have from the OECD. But whatever it is, it has to, I mean, we all have a stake in it being spent as efficiently as possible, as getting as much as we can for the dollars that are put in. And that is because of the opportunity cost. Every dollar that goes into healthcare through the provincial government treasury is a dollar less for some other expenditure, including education, social services, etc. So it's incumbent to be as effective and as efficient as possible. And again, this speaks to the innovation agenda, which could involve efforts to try to be much more effective at bending the cost curve or at improving for example, quality while still maintaining cost control, very effective cost control. And if bilateral health transfer agreements were used to encourage experimentation in those areas, we could see some real benefits for the country, because if it was publicly disseminated and evaluated, we would all see the results, and other governments would quickly adopt the more successful experiments, because they all have a stake in saving money.
Okay, we're coming close to the top of the hour. I've got one last question for you, Professor Marchildon. I think it's an appropriate one to finish on. I'll read it. According to the Federal Parliamentary Budget Officer, the federal government has more fiscal room in the long term than provinces and territories, and is in a better position to put more funding into healthcare. In the context of our federated system, what do you think about the obligation, moral or otherwise, for the federal government to pitch in and increase its share?
Well, I'll answer this in two parts. First, just to set the historical record straight. The federal government went from a position of lowering its contribution to healthcare in terms of the funding made available to the provinces and territories from the late 1970s to the late 1990s. Since that time, however, the federal government has been increasing its share to the point that it now, as I have argued in other writing, actually exceeds what has been its historic share based upon that historic cost-sharing arrangements under the Hospital Insurance Diagnostic Services Act initially, and then under the Medical Care Act in the 1960s and 1970s. So in that sense, I think that the federal government has been contributing a fair amount in terms of its reinvestment in the last few years. The question is, should it be obligated to provide more from a more sort of, in a sense, moral standpoint? I'm not sure about that, but I am fairly convinced that it could do more in certain areas, but that it should do more through either the establishment of a new national program that would be more effective than the current fragmented system of both private and public coverage as we have in pharmacare, for example. This would be a costly endeavor, but it'd be one that in the long run could be highly beneficial. So that would be one very effective avenue for the federal government to reinvest. Another would be through this idea of facilitating innovation. It might want to invest even more than $3 billion, for example, in that kind of innovation, but one in which there would be clear requirements in terms of data sharing, in terms of evaluation, in terms of reporting to the Canadian public. And again, that would be to really take full advantage of this laboratory that we have in Canada, of this decentralized federation, in which you have the potential for fairly bold experimentation on a provincial basis, and in which the benefit, of course, is that the failed experiment is limited in terms of its cost to one jurisdiction, but a successful innovation, because of the demonstration effect and because of potential federal government facilitation through cost sharing, could evolve into a pan-Canadian either program, national program, or a pan-Canadian adoption of an innovation that was pioneered in one province or another.
Thank you for that, and I want to thank everyone who sent in a question. There were a lot of very thoughtful ones. I think they were quite challenging to our speaker. Thank you, Professor Marchildon, for your participation today. The video of this webinar will go up on our website, and so you can watch for that if you want to share it with some of your colleagues. And just to mention again that the Insight, the IRPP Insight that Professor Marchildon spoke to today will be published next Tuesday morning, December 6th. So thank you again from IRPP for your interest, and we look forward to your participation on other occasions in other ways. Bye-bye.